So I'm talking this morning about some of the innovation that I get to see when I go around the country, and I'm always inspired by my colleagues. We are the fixers in the world, aren't we? In the ER, we fix it. Whether it be duct tape, safety pins, whatever we got to do, we make things work in the ER. I'm going to talk to you about some of the innovations that I'm seeing. I've just organized it in this way. We'll talk about spaces, what people are doing with their space, and it kind of tags on to Jim's talk about ED design. How about this, guys? Why not design for your ER? Why not look at your practice? Who do you see? When do they come? What do you do to them, for them, with them? And design the space to deliver those services. How many of you have had just the opposite? Someone builds you an ER and says, there, go be an ER doc. Right? They build you your ER and there you go. So we're going to bring in some of the ideas that people are using in how they allocate their space. Then we'll look at some new patient flow and processes and things that are being experimented with. Some gadgets and gizmos that you might not have run across. And then lastly, please stay for this because I think it's one of the coolest scheduling ideas I've ever seen for emergency physicians. And I thought I had seen everything. I thought I knew how the world was supposed to work, and these guys blew up my ideas. All right, so spaces. Whoops. Can you see in the middle of this room what's there? Hanging there. What's there? Yeah. How about this for part of your surge plan? Your overcapacity, the curtain gets pulled across. Now the room can accommodate both a bed and a chair. It's a two treatment spaces. So I've worked with an ER that had 100 beds, but believe it or not, they had a sort of a mass casualty kind of an event in their community that they had a huge surge, and they just did this. The other thing that I thought was brilliant was, what do you have to do with your EMR and your tracking board in the ER? It has to adjust, doesn't it? So guess what? Room 11 became 11A, ambulatory for the patient in the chair, and 11B. They actually could literally change the tracking system for their surges. So curtain pulled, flip the tracking system, and now you can see more patients. Don't you love that? Wouldn't you like even just a few rooms for when you have a surge that you could make quick double occupancy? Then how many of you are doing true vertical flow in your ER? Okay, you realize you are on the bleeding edge because this is very new. And I want to make a suggestion when you go back. I want you to go to infusion therapy and if you've got oncology services and ask them when they're getting new chairs. One of the most well-funded areas in your hospital. Did you have a question? Or? Okay, sorry, great. Okay, just because it is a very new idea. So vertical flow is the model whereby patients are not we don't get them naked, put them in a bed, put them on that stretcher, and there they go. We're doing something entirely different. We're keeping them upright. We're frequently keeping them dressed, and we're delivering care that way. Which, oh, by the way, do patients like it? Yes, they really do. In particular, seniors liked it. So people are now populating at least different spaces in their ER with these kind of recliners that are quite comfortable and keeping patients dressed and completely changing the way we've delivered care. So the idea that one size fits all, we're not doing that anymore, right? Because you know what happens. You get somebody naked, put them in a bed, and now it's nurse, right? I need to go to the bathroom. Mr. Wilson, you drove here. I'm quite sure that you can go to the bathroom on your own, but we make them invalids. So keeping them vertical, it really cuts time off of the ER visit. So remember I said, be friends with your infusion therapy and your oncology unit. Oncology is usually a very well-funded service line in your hospital and in your organization, and they turn over their chairs quite regularly so that they look pristine to the public. Why not grab a couple of those and create a vertical space for yourself? Maybe you start it with just 4 or 6 of them for patients that you think, well, they don't really need a bed, let's do that. Then the idea, bed minutes. You have 1,500 bed minutes per stretcher per day, roughly, right? Bed minutes, think in those terms. And I want you to be stingy with them. You get bed minutes if you have to lay down so I can examine you or so I can treat you. If you don't need that, I want you in a different place. And one of the other new ideas, this person still gets a bed, or these patients would, but now they no longer need the clinical intensity. They're going upstairs. They're simply waiting for that admission process. Could they go someplace else? So the concept of the express admission unit. Anybody got an express admission unit where they go where they're waiting for the bed to be cleaned? That's very progressive, right? Because you're hoarding your bed minutes for the ER. Then the idea of discharge zones of some sort. Is there a space where you could do all the discharge stuff that takes so much time? Because guess what? They no longer need your space in your ER anymore, which is so precious to you. So this whole concept of they only get the space when they need it. That's very different than the old model, right? Where everybody naked in a bed until I can say you go home. Everybody treated the same. Now we're starting to stream patients based on how acute they are and put them in different places. Now, the idea of a results waiting room, it's tagging onto the vertical flow notion. Can people sit up and wait for results? The old way, they would have occupied a bed for hours waiting for test results. So results waiting room, internal waiting rooms, the language is still being fleshed out. That'll be another thing that we'll have to do at our next summit, is tighten up some of the language for what we mean. But what we mean is places for people to stay while they're waiting for test results. And so I'm working with this hospital right now. Actually, they have a lot of space, but they have other, little collections of chairs and spaces. I say, could you identify, this is my, results waiting. Can they just sit there? It's within my department, but it's not occupying a patient bed. Could you take your waiting room, can you see off to the right of this picture, there's a bunch of these nice chairs that look out a window. It has a pretty nice view. With just theater rope, could you identify those? That's my results waiting room. Now, mind you, why don't we like a results waiting room that's outside of the ER? Because they could leave, right? But Arrowhead Regional, get this will blow you away, 120,000 visits. They're probably the place that's been doing vertical flow the longest. They only have 41 beds. Yow, how do you do that? 120,000 visits, think what I'm telling you. 41 beds? They see their patients in triage and they put them out front in a chair. They're only in the back as long as they need to get blood drawn and so forth. And most of their patients who can be vertical stay in the front part of the waiting room and wait for results. And Jody Crane has said, all you need is a theater rope and a sign. This is sort of similar to this. This is Intermount Healthcare. All of their appropriate threes, ECI threes, are going back in the main. There's a big waiting room, but they've put a little signage. This is your accelerated ED. You guys heard of this term. This is Jody Crane's model. And he basically takes that model to the next level. Vertical patients, we try not to give them IVs. They get oral meds, oral rehydration, get their tests sent off, and they sit in a chair that didn't look too comfortable, but you can see his model, and wait for tests to come back. What am I showing you here? So yes, these are called acuity adaptable rooms. I got all my stuff if I got to code somebody, right? But now I have more behavioral health that I can manage. I pull that head wall down. It's a fully retractable head wall. Pull it down, and it can be a behavioral health room where the patient can't get at stuff that they might hurt themselves with. Anybody got one of these? Oh my gosh. Well, sorry, it's not news then. Or it's not news to this room, very sophisticated audience. Last year, okay? Darn it all. All right. So then on patient flow and processes, there's a lot of sort of innovation going on at intake, then we'll come back to the vertical flow and build out a little bit, and then as they go home, outflow. So there's a number of ways that you could put that provider in front, all right? And we just know this to be a better model. And no offense to nursing colleagues, to APPs, who has the best reliability at sick, not sick, go, stay. We talked about this with the blink response. The physician trains longer, a lot more years, a lot more breadth of the education. And so they are better. So I like that model. I put my cards on the table. I'm partial to that model. But you can do APP and triage, you could do a team approach, but the idea is let's get the patient and the provider together as soon as we can. And I want to tell you where I think we're all going to be going as far as our patient flow. I think this will be the model that over time, as you get bigger, you will adapt. First, ESI 1 and 2, sickest patients, the 1s and 2s, they're going to go straight to an area, to a bed, with a provider in it, whatever unit you designate for your sickest patients. By the way, most nurses are very good at recognizing those 1s and 2s, okay? 4s and 5s, the least sick, you will be streaming likely to your lower acuity area. Fast track is what it was dubbed 30 years ago. There's plenty of literature that that's an effective way to do that. They will go, and they may see an APP instead of a physician, okay? What's that big bucket in the middle? The 3s, right? And the trouble with the ESI 3s, how many of you, do you know this? You see 40% ESI 3s. How many 50? How many 60? Yeah, so I mean, that it's in that range, and there is quite a bit of variation around the country with that. The 3s get fudged a little bit because a good intake nurse, to be honest with you, if she's not got no beds for an ESI 2, wherever you're treating them, she'll figure out something, maybe call the patient a 3 just to get them in play. You realize there's a little bit of finessing going on, and that's fine by me so long as we get patients back. So I believe that you will all eventually evolve to a model where whether you come by ambulance or whether you come by walk-in, and by the way, anybody got 20% patients come by ambulance? 30%? 40%. How come more hands are? You just don't know? You might not know off the top of your head. Fine, no harm, no foul. But we are seeing some ERs that are having 40+% come by ambulance. So in the old days, did you say every ambulance patient got a bed? You can't do that anymore, right? You just may not have enough beds. So whatever entrance you come by my ambulance entrance, you come by my walk-in, I believe you will stream the sickest, the 1s and 2s, to a doctor, to a bed immediately, the 4s and 5s to the fast track, and the 3s will go to a provider in triage. And start that work up fast. That model is showing amazing results, and I believe that's where you will likely all go. Now, to say that you're going to go, though, to a physician in triage, whether you send everybody or just the ESI 3s, so now we're realizing that's a huge bag. That's quite different. You can do it with the idea, Jody Crane's idea, which is they're going to carefully select out these 3s. They can sit in a chair, take stuff orally, and not have to lay down, not have an IV, and then go home from there, right? The other extreme is to put your physician in triage to do a quick workup, quick assessment, start the workup, and then the patient may go somewhere else. Do you see what I'm talking about? Are you going to have the doc see them and send them home? Is that going to be your model? Or are you going to have the doc see them and they go somewhere else? And then everything in between. We've seen, I talked to, probably Jesse Durando has more experience with physician triage than anyone. As you know, EMP has rolled it out at all of their sites. And I talk a lot about the different ways that you're going to adapt this. It's going to depend on what your makeup of your patients is, what your admission rate is, how many geriatrics you have, right? How many spaces you have. So to say that you're doing a physician in triage is not to say a whole heck of a lot, because the way you implement it could be so different. Does that make sense to you? That it's not one size fits all. There's very many ways to do that. And I told you, the reason I like this is because you are so good at this as the physician. You're very good at this. So Arrowhead Regional, the one I keep mentioning, 120,000 visits and 41 beds, oh my God. They have found that only 1 in 5 patients actually has to have a bed. And I suspect that you're going to find something like that if you do this. 29 to 45%, depending on who you read. And a lot of this, actually, you can't read it. It's just by word of mouth. But in talking with bigger hospitals that have experimented with it, that's what it looks like. 29 to 45% can go home with very little. Maybe a prescription, maybe instructions, maybe referral. But everything goes faster when you get the provider and the patient together and start that workup. So I really love the model of at least have a provider see them, get labs drawn and sent off, even if they have to go back to the waiting room. That's going to be so much more efficient than making people wait. And do you know, by the way, it looks like it is ending up that this big bucket of 3s often waits longest. Can any of you track door to doc and length of stay by ESI score? When you start doing that, you'll see, well, gosh, we get the quick and easy to the fast track real quick. We know sick when we see it, so if you're going to die, we get you back sick. But you're for that big middling group, you often wait, right? Especially if the department's over capacity. And there's a ton of literature. Can I tell you what? I don't know where to stop when I try to make the case to you for streaming of patients, starting with the literature on fast track. It works so much better. That said, you still ought to have some flexibility within your area of what you will see, right? But streaming just seems to make so much good sense. Now, if you're going to put a doc out front, the reason I've seen it fail is people don't properly resource it. So if you say, I'm going to try physician and triage tomorrow in my shop, I'm going to go out there and be the doc in triage. Is there any way that's going to work? Probably not. What are you going to do out there by yourself, right? So now you could go see the patient, assess them, maybe write some orders, and then nothing still happens, right? So I always say, make it very tech heavy, and I know Jim Augustine believes this too. You'd almost rather have techs than nurses out in physician and triage to just support the workflow of the doc. If you're going to require any kind of documentation, then you might put a scribe out there if you've got them. Okay, and by the way, most EMRs have a way to adapt the support and the documentation for an ER visit where one provider starts the workup and the other finishes it. And if anyone tells you otherwise, I was doing this with a group that had just gone live a few months before with Epic. I got the longest email I may have ever had in my life, 2,000 words. Do you know how long a 2,000-word email is? It was from a physician in the group, how we could not do provider and triage because Epic wouldn't let us. Within 24 hours, I'd found a half a dozen different ways to do it in Epic, including a shared note, by the way, for those of you who have it, where a doc could see and start a workup and hand off the patient to the back. So 2,000 words. Huh? It was stunning. Anyway, so to make it work, these are the things that you have to really pay attention to. Do I have the supplies I need to do my labs and hopefully line? Though this is problematic. How many of you can have your techs do lines, do IVs too? How many can your techs in your ER do lines? How many they can only draw blood? I think that's probably the more common. And that's a little bit tricky because you know what, sometimes you wind up sticking people twice. If they're seen in triage, you start the workup, they go back and someone decides they need a line, it's a second stick. But talk to the state about it, right? If I could do it otherwise, I would do it differently. All right, now, we talked about, so this physician in triage, what's it going to look like? And you really will have to decide based on your resources. Will they go out to this waiting area out front, like you saw the Intermountain model there? Will they go to some designated zone? I like it when you start putting Barca loungers and have a designated zone for most of these threes. Or are you going to go to a different internal waiting room? You will have to decide where they'll go. And it's your real estate. Right? You never think about this. It's the luxury that you have. It's your department. It can look and flow however you want it. Another thing about vertical flow, there's really two iterations, and wrap your mind around this. So I see a group of patients and I think that they can stay vertical. They're not getting naked, they may not get a line, they're going to be treated in a chair, we're going to expedite their care, which, oh, by the way, I've got one place that's doing vertical flow that is turning patients around. Now, mind you, these aren't fast track, these are vertical flow patients. In 100 minutes, I'm thinking it can probably be pushed even faster, you know. But then how about this? How about you've had somebody there for 4 hours, or heaven help you, 6 or 8 hours, they're likely to get to go home. You really need the bed because the ambulances are pouring in. Can you make them vertical flow on the back end? And so I've actually encouraged some ERs to work with them, and they're loving it. They were calling it bed ahead, where the patient, when the ER is getting capacity, the flow nurse will say to the doc, who do you think is going to be the next to go? Do we always get it right? No, but you're about 95% reliable, good enough. The doc will indicate, I think these two are going. This one I'm just waiting for a call back from the ortho guy. This one I'm waiting for urine, whatever. So those patients are then dressed and put in 2 chairs in a space within that zone because you've just opened up 2 more beds. So can you see this 2 iterations? Vertical flow by design from the beginning, right? Or someone who's needed a bed but no longer needs it, can they get back vertical and be vertical at the end? So 2 different manifestations that you should consider. This is University of Kentucky, their vertical flow. It was this ER that I talked about, did just what I said, went up to oncology, said, when you're done with those chairs, could we have them? They just put this, they found this little nook here that they weren't, you've got nooks. Do you know this? You have nooks. Go in your department and look for the little spaces. It might be a closet that has stuff in it from 1982. It might be just a hallway. You likely have a little space that you could make be a place where you do some vertical flow. Can you see the T on the wall? They just identified the zone. They'll have signage shortly, but that's going to be for some of their vertical flow patients. All right, then getting them out. Remember, they only get the bed as long as they have to have the bed, right? So these are some of the newer things. Oh, and let me ask you, anybody doing discharge teams? And it can be impromptu. So let's say you're looking at their board, it's full, you need some beds. Can the flow nurse say, all right, Jill and Tina, I want you guys to become a discharge team and just get rid of all these, get rid of everybody who's about to go. Can they just go quickly? Because you know what happens. If Tina has an MI in room 1, all of her people flag to go home. When you do primary care nursing, just sit, right? And so do you think patients like it? All right, so here's the script. Mrs. Wilson, we've got an arrest and your nurse is in the room with a really sick patient. You can wait for your primary care nurse to discharge you, or I could discharge you now. What do you think they say? I'm out of here. Thanks. You know, bye-bye, Judy, I'm going, you know. So patients, as much as it's a time-honored tradition to have primary care nursing, the value for the patients is probably not as much as we think. Then a discharge zone. This was a discharge zone where they actually, so there's a dialogue with the patient at discharge about what's going to happen, but they go there for discharge paperwork and, oh, by the way, the other nasty thing we have to do, collecting payment information. And guess what? They're not missing so many patients since they set this up, their financial information, their insurance information, because they got to go there to get their paperwork, instructions, referrals, and prescriptions. So they don't run away from this. They actually go. Unless they wanted Percocet and couldn't get it. Then they might just hightail out of there, right? You know what I'm talking about. This ER, they actually made this impromptu for registration, that they could do discharges and registrations. It's your real estate. What do you want it to look like? How do you want it to function for you? Here's another, we talked about this before, express admission, the idea of now they're on their way out, can they go here instead of to occupying my ER bed? Couple of gadgets real quick. Anybody of you got one of these? I think it's kind of been nicknamed the nurse's friend. So it's for a bedside ER nurse. It has all of the stuff that she needs. She can use her ID badge barcode to acknowledge that she's opened it up. And everything is weighted so that it tells you what's come out of the machine. So that stocking is really easy, because when you open it, if you're the stocking person, it tells you on a computerized screen what needs to go in there. Don't you love this? How many of you run around, like my favorite is the glove on with the poop, running around looking for developer, right? That's my favorite in the ER. So we run around looking for supplies. This, at least from a nursing standpoint, has the supplies and some of the stuff docs need. Email me and I'll get it for you. I've got it in my file. I can't remember the official name. I just remember they nicknamed. Who knows what it is?
It's a nurse server, nurse supply server, generically.
Okay.
There's several brands. You've got the linen and too.
Yes, I do.
Which is great to keep EMS from stealing all your information.
Yeah, so can you believe it's computerized so that it knows the weight of a gown and sheets and so forth, towels, whatever. And so it tells there's kind of like a Naugahyde cover thing that pulls over. But when you open it up, if you were to look to stock it, it'll tell you need 10 more gowns. Don't you love this? Where has this been all my life, right? The stuff I need, keep it stocked for me, please. All right, this is kind of dark. Do you know what that thing is on the wall? It's an ambulance charger. Who thinks they've got the highest number of ambulances a day? Compared to it's like we're playing cards here. This is Las Vegas. I've got a hospital with 120 ambulance arrivals a day. 120 ambulance arrivals. Anybody beat that or meet it? Close to it? That is a lot. So do you know what I really worry about when I go on-site visits? They back up to the entrance to the ER, right? And what do they leave their engines doing? They're running the whole time, right? I don't begrudge them. They want it warm. They want, you know what I mean. I don't begrudge them. I just worried about the ambient carbon monoxide levels. So here, this is actually at Grapevine Hospital in Texas, and actually we have one of their medical directors in the back, don't we? Anyway, I think he's here, around the course. Anyway, you can plug in and keep your engines running without using fuel. The other solution to that problem, by the way, is they have vacuum systems that will hook up to the exhaust and pull the exhaust away from the ER. But you know what? Guess what? Think of human error. What mistake was somebody going to make? They drive off hooked up, right? Yeah, you can imagine what a mess that is. They're tethered by this tube to the hospital for their exhaust, and they drive off with it. So this is, I thought, was a great, and my understanding is if you're trying to court EMS, they really like this. They can come in and just plug in and charge their ambulance. Anyway, we talked yesterday about making sure that you have enough IT. This is the thing that we've underestimated, is how much workflow would be dependent on IT, and we don't usually have enough computers. I say a station for everyone, every work member on the team, tech included, and 2 screens for everybody. All right, so here's that hospital that I told you about yesterday. Remember the one that looked like a museum? Right? You can't even believe it's a real ER. This is the ER looking their main hallway down. It's like the length of a football field. Can you get that impression? This is often, for what I'm going to tell you how they run this, and this is the thing that I think will blow you away, because I'm still blown away by it. It's not the best design for it. Now, in your book, notice this, start right to left. They've got the different sort of pod design. At the top, the blue, there's some intake beds. Let me show you what that looks like. They have 10 beds, the possibility to take in 10 patients at once. Do you think intake becomes a bottleneck? It does not. They do a very rapid, efficient nurse assessment that's just 2 minutes long. They started these little dental chairs, and then it's decided where they will go. So I typically like, as you know, physician in triage, but this is nurse in triage, but it really works the way that they've got it. They've got capacity. It feels clean. All right, so that's that area right there, blue-green at the top. The far right is the pink zone. That is your critical care. The next two, the blue and sort of yellow, are the major medical. And on the left-hand side of the slide is sort of an orangey color. That's their fast track. They call it quick care. As a physician, when you come in, you start in critical care. Part of the idea is if you can't disposition your patients in 8 hours, shame on you. You got 8 hours, so you're starting with your sickest patients, the ones that take the most mental energy, and that's how you start, okay? At 2 hours later, a new doctor comes in, you move over to major medical. You are inspired, remember that long hallway? You are inspired to disposition your patients efficiently, because otherwise you get too far away from them. They're all the length of that map that I showed you, okay? So you're inspired to keep things moving. You start with your sickest patients, then you move to your intermediate patients, dispositioning as you can. Wait a minute, here, sorry. And then you go to the very back, that fast track, quick care, and do low acuity. And think about that. So low acuity certainly requires less mental energy than the higher acuity complex, gee, do I have to admit them, that kind of a thing. But here's so this schedule, is this different than anything you've heard? There's variations on it. In the old days, we would call it falling back to the fast track. Anybody remember that from the 80s? You'd start out in your major ER, and then you'd fall back to your fast track for the last part of your shift. But here's where the great innovation is. So these docs are arriving every 90 to 120 minutes, you fall back, but then look at the last 2 hours. Can you read that? The last 2 hours, you are the procedure doc. What do you think of that? How many times have you been doing a laceration and you get 10 interruptions? Oh, the stroke doctor's on line 2, and you think, gosh, I wish I wouldn't get interrupted. Or you're going for an abscess and you're like, I know there's pus in there. Why can't I get it? And you're interrupted. Wouldn't it be nice to finish your shift just seeing these procedures? Shari, I need an LP in room 3. Got it, no worries. Turn my brain off. It's all tactile procedural stuff right now. And oh, by the way, if there's no procedures at your 7.5 hour mark, you get to go home. Do you think it's a crowd pleaser? So everyone leaves on time, physician-wise. What's a huge dissatisfier, right? It's that, having to stay after 1 to 2 hours. Wouldn't that be wonderful to come to work and go, I might get out early today. Let's see, right? And so let me show you. It shouldn't work. They are running the length of their ER, right? They're not into dedicated teams, pods, and zones, which is what I've been talking to and I truly believe in. But this works great, but this is a very unique ER. It's the one I mentioned to you in Fort Worth, and I hope I'm not beating it to death, but I really appreciate it. And I kept on hearing, well, it's better for the patients. We do it that way because it's better for the patients. It hinges on great communication that they didn't build overnight, by the way. I've never seen such a tightly run shop. Let me show you this. On their performance, do you remember this? I think we skipped over it real quick yesterday. So 328 patients a day, door to doc, 17 minutes. Overall length of stay, under 3 hours. Even admitted patients are going up in just 4 hours, less than 4 hours. And no walkaways. Left without being seen is less than 1%. What do you think? Don't the physicians kind of like it? And oh, by the way, this seals the deal, okay? If you look at hospitals that are similar in the AAEM database, you can see they're using 208 doctor and mid-level provider hours a day to staff that population. This hospital in Texas is seeing more, and they're doing it with 112 doc hours. They don't use any APPs. And look at that performance. Don't you think that's just astonishing? Anyway, so I'm like, oh yeah, because it's something, it's different. It blew up all my ideas for how you run an efficient ER and how you staff it and so forth. And yet there's so many things that are intriguing about it, aren't there? And this is the place, marry this concept with the red doc, green doc from yesterday, because that's the other piece.